All right, folks, we've got Dr. Tim Ryan on the line. He's the director of the Board of Health here in Clear Creek County, and we're going to catch up on all of the latest COVID news. Good morning, Dr. Ryan.
Good morning, Mike. Mark, how are you?
I'm doing just fine, thank you. I was just on the CDC website, and I took a quick look at our overall trend, and it looks like we had a pretty good week, and they are only reporting until Saturday, but looks like things are pretty good up to that point. Why don't you bring us up to date?
Well, Mark, I would caution that assessment in the fact that Thursday, Friday, Saturday, and Sunday there was very little testing going on across the United States and very little reporting. So I would more focus my attention on this week and the numbers that come out, because they're going to be sort of that catching up from that gap of information that was there over the last 4 days over the Thanksgiving break. So right now the trend is continuing that we had seen over the last several weeks and a month and a half or so, with a significant increase in cases across the country. Colorado and Clear Creek are right in the same boat as the rest of the country. A significant increase in cases, significant increase in hospitalizations, and the subsequent increase in fatalities.
Well, I guess that's about what we had expected, and maybe all that we could hope for. I wonder, Dr. Ryan, when I think about the infection rate, and I know that there are false negatives and false positives, and so the actual hard number of infections is only relevant in so much of it's a trend. Is that accurate to say?
Well, the case counts have continued to increase, and now we're in what's considered exponential growth, meaning the growth is so fast and quick. We're seeing what we saw take several months to achieve, meaning a million cases of COVID, is now taking mere days. In the last week and the last 2 weeks, we've achieved 1 million cases in less than 5 days. It took us months to achieve 1 million cases in the beginning of this pandemic in March, April, May. Now we're achieving that in just a matter of days.
Well, I'm thinking about the actual case count and the way that I look at. I take my blood pressure every day, and there's a slight variation day by day, but I try to follow the trend of it. And if I had a fever of some kind, I would be looking at the trend, not the absolute number. And that's kind of the way I've been thinking about the case rate, because it's not an absolute count of how many cases there are. In fact, it's probably a substantial undercount. Am I off in the weeds here, or is that the way to look at it?
No, that's correct. We know that roughly 40 to 60% of individuals who are COVID positive are asymptomatic out there in the community. So if you think about it, just a small fraction of those individuals will actually get tested. Because they're asymptomatic, it's not going to promote them to get tested. We're relying on people just going and getting tested, particularly the ones that are asymptomatic, to identify them. So we, of the 1 million plus cases that we're now achieving in a week's time, that's a fraction of what the total count is. Obviously, we can't count people who don't get tested. But based on the information that we do have, we know that the people who are actually counted as cases are but a percentage of the total cases that are out there in the community.
Well, that's what I was afraid you were going to say. So in light of that, I know that there's also statistics around hospitalizations and deaths. So we have a case count, we have a hospitalization count, and we have a death count. Which of those or all of them should we be looking at in totality, or is there one significant number that kind of trumps the others?
Right now, how it works is this: as cases increase, and that takes weeks to achieve, and we've seen that over the last 6-7 weeks or so, a steady increase, and now a much steeper incline of cases. The hospitalizations and fatalities lag behind that, in that it takes days and weeks for individuals to become ill, then become so ill that they now require hospitalization. And then once they're in the hospital, that again potentially takes weeks for them to die. So there's a lag between case count, hospitalization going up, and subsequently fatalities. But what the models have been showing us for weeks now is that increase in case count will eventually result in increased hospitalizations. We're now seeing that in spades across the country. Many states are now in the point of sort of emergency care in terms of they're deciding who gets a bed and who doesn't, because ICU beds, there's only so many of them. And more importantly, there's only so many staff. So it's one thing to keep in mind and important to remember is that adding 600 or 700 ICU beds that don't include a doctor and a nurse with them isn't really helping. Unless that bed has staff members associated and tied to it to help the patient, an additional ICU bed is not terribly helpful. So what we're seeing now in the last several weeks is a significant increase in hospitalizations, and now, several weeks later, that the fatality rate is increasing as well. The concern, the major driving concern, is when the hospitals are now overrun, where there are no more beds. And when that happens, the mortality or the fatality rate will go up exponentially. If you don't have an ICU bed and you need one, the likelihood of you dying significantly increases if you had one.
Well, speaking of ICU beds, I can reflect on my own experience. I worked at Lutheran Hospital in the emergency department for close to 15 years, and we would take patients up to the ICU, typically heart attack or stroke victims, others as well, sepsis patients, etc. But I just don't remember that many empty beds under normal circumstances. I just not being there in that environment anymore. It's hard for me to imagine how they are accommodating the additional caseload around the COVID. What can you tell us about that? Have they had to convert different floors to ICU beds?
They have. As you alluded to, heart attacks and strokes, they're still happening, and they're not on pause. So hospitals are having to make great accommodations to both accommodate those individuals as they always have, but now accommodate COVID. And most hospitals that I'm aware of anyway are having a separate COVID unit. They obviously do not want to mix stroke patients and heart attack patients and those sorts of individuals with COVID patients. So they have a separate, most hospitals have a separate wing or separate area that's only for COVID patients. And then pushing a lot of those other people into different wings and different sections of the hospital. So it's requiring a lot of juggling in logistics for the hospitals. And they only have so much room. They only have so many beds. And most importantly, they only have so many staff. And those staff are incredibly exhausted. Many staff have not stopped working and haven't had a day off since the beginning of this pandemic and have continued on. And they're going to be pushed to the brink, particularly if hospitals are overrun with patients. The entire public health infrastructure's priority, it has been and continues to be to avoid the rush on hospitalization and hospital, because we know once that happens, the fatality rate is going to go up significantly. And we're trying to do everything in our power to keep people out of the hospital and subsequently keep them from dying.
You mentioned doctors and nursing staff, but there's so many other associated staff that are required to care for patients, especially respiratory patients. The respiratory therapists have to monitor every one of those patients, and there's just so many of those folks to go around. I don't know how they're coping with that. They must be training staff in-house to do specific narrow responsibilities to try to accommodate the number of respiratory patients they have right now. I just don't know how else they're doing it.
Yeah, that's exactly what happens. I spoke to a good friend of mine yesterday who's a ER physician down in Albuquerque. And most hospitals now are no longer doing elective surgeries, and they're shifting the staff from those elective surgeries and surgical theaters to other parts of the hospital to help with the COVID. So a nurse who used to be in the operating room is now a nurse up in...
Yes, Dr. Ryan, you faded out there at the end of that conversation, but I wanted to say to ask you something else. I was looking on the Colorado COVID website, and excellent information both locally and at the state level. And on the state, I saw a graph that broke the COVID cases into decades of life. So they had 0 to 10-year-olds and so forth up into 80-year-olds. And one thing that I know, the population percentage within that age group, and then the COVID percentage within that age group. And it struck me that 20-year-olds, 20 to 30-year-olds, and 30 to 40-year-olds were the highest incident rates as depicted in that graph. I wonder what you think of that. Oh boy, Dr. Ryan, we seem to have lost Dr. Ryan here.
Yeah, that sort of statistic's not surprising in that the 20 to 30 or 20 to 40-year-old really age group are the ones who are continuing to push the limits and continuing to socially gather, go out to the bars, and that sort of thing. So they have, in relative terms, the greatest amount of exposure of anyone in the population. So it's not surprising then that they would be the most infected as an age group. Yeah,
the significance of the virus to them personally, in terms of how sick they are, is relatively low. But ironically, they're spreading that to others, and that's why I guess I've been hunkered down for the last 8 months and have a light future ahead of me. I wanted to switch to another aspect of the infection rate. The way I look at it, Dr. Ryan, Halloween kind of primed the pump for our November COVID rates, and Thanksgiving, unfortunately, is priming the pump for December rates. And I can't even imagine, now that we are in this phase of exponential growth, what the implications for January might be when we have Christmas and the New Year's holiday between now and then. What do you think is, look in your crystal ball if you could for us?
The picture isn't good. I'll be quite frank with you. As the previous holidays, 4th of July, Labor Day, Memorial Day, have taught us, we're going to see a spike. I think, and many of the other experts agree, that this spike is going to be particularly large because of the indoor nature of Thanksgiving, as an example. And most people are now inside in the United States, at least in the northern half of the United States. So only feeding further the potential for growth, and we're seeing that now in the numbers. Christmas, I hope personally that the huge spike that we may see coming out of the Thanksgiving week in the next week or two will help educate people even further to show that when you do the opposite of what public health across the country tells you to do, it will result in a significant increase in cases and hospitalization and subsequent fatalities, that might motivate people to not do what they normally do at Christmas and New Year's this year and take a different approach to their behavior. That remains to be seen. If I knew the exact number and exactly what was going to happen, I'd be in a very different position. But my educated guess, based on all of the information that I have, the next couple weeks, in addition to the next couple months, are going to be very, very difficult for this country, both in terms of the case count, but more importantly, hospitalizations and fatalities. Those numbers, once they reach a certain point, it's going to get much, much worse for reasons we've already discussed. Once hospitals run out of ICU beds that are attached to doctors and nurses, that number, the fatality number, will grow exponentially, which is what we've been trying to avoid all along.
Do you think that the hospitalization rate is the major driver in the state's decision as to whether they would consider going to level purple? I mean, if the hospitals become overwhelmed with cases, what other choice does the state have? I don't know where that goes.
Yeah, that's. I believe you're correct. The single most important variable from the state's perspective, if the state no longer has a medical infrastructure because it collapsed due to overuse and has the ability to address the incoming patients, the state, in my opinion, really has no choice but to shut down. We're seeing that in a couple of states now where they are going back into lockdown because their hospitals are absolutely overrun. You can't continue as business as normal if your hospitals are unable to actually accommodate the patients who are coming in. And the only way to slow the spread, unfortunately, at that point, is to shut the state down. It's not going to be a perfect solution. There's still going to be spread and hospitalizations and fatalities, but it is the single most effective way to slow the spread. If people are clearly not going to change their behavior in wearing masks and not socialize and not socially distance, the state will really have no choice but to shut things down and limit the amount of movement that people have. It's how a lot of the Asian countries were successful in basically minimizing the impact of COVID in their country. People listen to their government and the public health apparatus in their government, and they do what they're told. And when you do what you're told, from a public health perspective, it does have results, positive results. We see that in countries all across the country, all across the world.
Yeah. Well, I guess I'll mention this. I was also reading today that Goldman Sachs, the big banking outfit, they did a financial study of the impact of COVID. This was back in June, and they estimated that not only could 130 million lives be saved if everyone wore masks, but the financial impact of not wearing masks as opposed to everyone wearing masks was $1 trillion. That's a T, $1 trillion. And so I just find the argument about this black and white argument about shut the country down or save the economy. I find that specious because they're so interconnected. And here we are talking about shutting down the state of Colorado because the hospitals will become overwhelmed. Why? Because we can't follow a few simple rules. I don't know what to say other than, you've been preaching it, and there's a certain segment of the population that just doesn't seem interested in conforming. And I look with envy at Japan and in the way that they have been able to conduct their normal lives throughout this whole thing. Why? Because they follow a few simple rules.
Yeah, Mark, I some days I struggle to understand and to explain, but it's in my opinion, it's pretty straightforward. You can't, at one sense, say I'm an individual and I don't want to wear a mask because it's my right, and on the other hand, say we shouldn't close down the state or the country. This isn't a big deal. Both sorts of arguments are based on complete ignorance and understanding of the virology and epidemiology and immunology and the spread of diseases. When you choose as a collective society to pretty much ignore the experts, the subject matter experts, people who actually understand what the potential is of this, then you get into a situation that we're in. By sheer definition, a pandemic means it isn't actually about you as an individual. It's not about your rights or what you may or may not believe in. It's about the collective whole, right? The pandemic is worldwide. It affects every human on the earth. And when you start to look at it from the perspective of me, myself, and I, that's when you get into a situation that we see now here in America. We have a good portion, almost 50% of the population in America believe that mask wearing is not necessary and social distance is not necessary. You also have people who are dying of COVID in ICU units who say to the nurse, COVID doesn't exist. There's lots of anecdotal examples of that across the country. People are in absolute denial that COVID is actually real. I think that speaks volumes about what's going on in this country and the misinformation that's been occurring over the last several years, that people don't even know what to believe. Even in times of a pandemic, when tens of thousands of people are dying across the country, and there's still people who believe that it isn't real. To me, that speaks volumes about the need for education. It also speaks volumes about the importance of funding and supporting and providing background and foundation for the public health apparatus in this country. We're a developed country, yet we have one of the worst public health infrastructure of any developed country in the planet Earth. I think that speaks volumes about what our priorities are in this country.
Yeah, well, here's one more grim statistic. The U.S. has 4% of the population and about 20% of the COVID deaths. I think that's a reflection of what you're describing, and I guess that's a larger question of why have some people in power for decades now tried to convince the American public that the institutions were corrupt and inefficient and not to be listened to, not just today, but every day. And I just don't know why they would do that. It's so destructive, and here we are paying the price for that. Let's get on another subject. Let's move on to the vaccine, which is we are in this dark tunnel, and there is this glimmer of hope and light out there in the future. And I know that. We've got two, Moderna and Pfizer have been authorized. They have applied for authorization for emergency use. They've applied to the FDA. I read that application is 100,000 pages. They're pouring through that right now, and it looks like in 2 or 3 or 4 weeks we may have the first vaccines available. What do you think that timeline looks like?
Yeah, you're correct. So there's currently two that are the closest to the finish line, if you will. The Moderna and the Pfizer. The Moderna one will be reviewed by the FDA the 17th of December, and the Pfizer one will be reviewed the 10th of December. It's my understanding, and the many conversations I've been a part of with the state around the vaccine, is the intent is to ship out the vaccines literally the same day or the next day after they get FDA approval. The vaccines in this case, and this is the exception. This never happens. The vaccines were manufactured simultaneously to the phase 3 trial. That isn't done typically because of the financial risk of generating and producing a lot of vaccine that may or may not show efficacy in the phase 3 trial. But they went ahead and manufactured it simultaneously, so that vaccine is already ready and will be shipped out shortly after they get the FDA approval. The way it's going to work, in theory anyway, is the manufacturers are going to ship them directly to the states across the United States, with Pfizer being the first one. These first 2 vaccines that are available are particularly logistically challenging. The Pfizer one in particular needs to be kept at negative 80 centigrade, which is very cold, and it is very difficult for many places to keep it that cold for a long time. Typically, the only places really have a negative 80 capability is hospitals and universities, typically. So a lot of the more rural counties in this state won't have the ability to keep something at negative 80 for very long. We're going to be relying heavily on dry ice. Once those vaccines are received by the state, they will then subsequently be dispersed throughout the state to the individual counties. The CDC is deciding today who is to receive that first round of vaccines, and in this case, the Pfizer. The way they broke it out is there's a Tier 1, and then there's a subset in Tier 1 of A, B, and C. A being in-hospital doctors, nurses, the front line in the hospitals of people treating COVID patients are to receive the first set of vaccines. The challenge with this is the first 2 vaccines also require 2 shots, 30 days apart, roughly. So you have to get a shot on day 1, and then a month later get the second shot. You can only get the same shot that you received the first time, meaning if you got Pfizer, you cannot subsequently get Moderna for your second shot. So that adds an additional logistics challenge. So the first several months of our vaccines will be going to the Tier 1 individuals across our county and across the state. So once we get past the medical staff, we're going to be immunizing our EMS, fire, police, and those sorts of positions that have the highest risk and highest level of potential exposure. It will be realistically probably May, June, sometime in that time frame where the rest of the population will have access to actual vaccines. They're going to continue to ship those every month, and we're going to continue to identify the next round of individuals and then provide that vaccine to them. It's free of charge. It will be for Clark Creek County residents. We are right now putting together in the early stages of putting together sort of a fact sheet around the vaccines, and our delay has been some of this information changes day by day and week by week. So rather than continually change the information we provide, we're waiting until things sort of settle down around the vaccines in terms of which one we're getting, how many we're going to get, and that sort of thing, to share that information with the general public. I want to do say, because I know there's been a lot of talk and a lot of interference, if you might, around the politicalization of the vaccines. This vaccine, the Pfizer, the Moderna, the Johnson & Johnson, AstraZeneca, they've gone through the exact same rigorous guidance and rigorous regulation that any vaccine that's ever been developed has gone through. The vaccines themselves, the individual companies, they have an independent review board, meaning these individuals do not work for Pfizer. They're scientists, they're epidemiologists, statisticians, medical doctors who do not work for the companies. They merely review the data and are blinded to the data. So they will be looking at the data, and they first and foremost will decide, one, if it's efficacious, meaning how effective is it at protecting you, and two, is it safe? Once that independent review board approves it, and this is where we're at now with Pfizer and Moderna, they will send all of the data on to the FDA. The FDA also has a politically independent group who are statisticians and epidemiologists and virologists, et cetera, who will then subsequently review that data, and that's what's going to be going on the 10th of December for Pfizer and the 17th of December for the Moderna vaccine. Once the FDA reviews all that data and approves it for its efficacy and safety, They subsequently send it on to the CDC. The CDC also has a completely independent group, politically independent group of scientists whose sole purpose in life is to review these sorts of things and make sure that they're safe for the American public. They, too, will review it in great detail. Once they do that, they will then send that information on to the states. California, as an example, has set up a similar independent review board of statisticians and epidemiologists and medical doctors, et cetera, to subsequently review that data as well. So there are many layers to this, sort of guaranteeing the safety and efficacy of the vaccine. It's going through the exact same process every other vaccine you've received goes through. So I'm very confident that what comes out of this in the Moderna and Pfizer and Johnson & Johnson and AstraZeneca vaccines and all the others will be safe. They will be safe for the American public. And given the numbers that we've seen subsequently from Moderna and Pfizer, not only are they safe, but they're incredibly effective in protecting individuals, not only from COVID, but from severe COVID, meaning you're not likely to get it. And if you do get it, you're very unlikely to end up in a hospital or end up dying, which is what you want out of a vaccine.
Well, that's just wonderful news. It's just the vaccines that have been developed, it's just incredible how short a time it took for them to be developed and how efficacious they have been in trials. But let's talk about that efficacy for a moment, because I think this gets to the heart of a problem that we have, and I know that that whole description you just went through to reassure people of the safety and effectiveness, the efficacy of the vaccine was to try to encourage people to become vaccinated. And being vaccinated is different than the vaccine having a certain proven efficacy. And so that's efficacy versus effectiveness. And effectiveness is a different thing. That has to do with how many people have been vaccinated, how many people became sick, because we can't know all of the details of who might become sick just based on the phase 3 trials, how many people don't become vaccinated, etc. So I just think that that's it's such an important aspect of this, and I hope that maybe Dr. Fauci will go on television at 79 years old getting his vaccination, and let's get some movie stars and other personalities and the world's greatest advertising agencies working on breaking down people's resistance. What do you think of that?
Yeah, I think you're correct. And one of the things that clinical trials do is they've covered in those 4 vaccines, the Moderna, the Pfizer, Johnson & Johnson, and AstraZeneca. They have vaccinated tens of thousands of people across not only the United States, but across the world, in Brazil, in England, in South America, and Africa. And they've tried to include in those clinical trials individuals from 18 years up into the 80s and above. Also different ethnic groups and different genders, obviously, and all those sorts of things to try to cover all the bases in terms of how individuals may or may not react to the vaccine. There are going to be side effects like any vaccine, but they will be minimal, and that's what the study in the phase 3 clinical trial is looking at. Are there side effects? And if there are side effects, are there any that are significant? Minor side effects are expected with any vaccine. You have a sore arm, you may feel nauseous, you may feel minor symptom, this or that, but they tend to subside in a day or two. I think you will see, in fact, Dr. Fauci and others who have dedicated their entire career to this sort of thing, standing up and promoting the vaccine, or all of the vaccines for that matter. It's going to require roughly 80% of the American population to get the vaccine for us to generate what's herd immunity. Between those who've already gotten COVID and those who subsequently get vaccinated, it's going to need to be near that 80% mark for us to have, what everybody wants is getting back to normal. if you want to get back to normal, the quickest way to do that is to get vaccinated. It isn't a panacea. It isn't going to fix things immediately. I think that's a very important thing to remember. Even with the vaccine, because of the regimen that I just described, in that it's going to take many months to roll this out and many months to get everybody vaccinated who wants to get vaccinated. In the meantime, we need to continue to social distance and wear masks, and these numbers are not going to slow down because magically there's a vaccine available for a small percentage of the population initially. These numbers don't care that there is a vaccine on the horizon. The virus is going to do all that it can between now and when everyone gets vaccinated to do as much damage as possible. And we're seeing that in spades right now in the numbers across the United States, and are going to continue to do so until we as Americans take this as serious as it is.
Yeah, I'm glad you mentioned masks again, because one of the things that I've read in a number of places is that right now they have some great idea of how effective the vaccination is going to be. But one thing that they don't know is will you still be able to transmit virus from yourself to someone else, even though you have been vaccinated? And so, maybe because I'm old and maybe I've got a comorbidity, I could be high on the list of folks to receive an early vaccination, but that doesn't. Nobody knows yet whether or not that will provide me a barrier to the virus, and I won't be able to transmit it to someone else. So I'll still have to wear a mask even once I'm vaccinated. Am I reading that right?
Yeah, there's lots of information we still don't know conclusively. I think there's some historical information that we can rely on from other viruses, et cetera. But the likelihood of if you are vaccinated, the likelihood of you getting it and subsequently transmitting it to others dramatically goes down when you are vaccinated, right? If you are exposed to someone who's COVID positive, your body is going to fight it instantly. So it isn't going to be around in you for the same duration it would normally have been if you hadn't been vaccinated. But there is this window that we're talking about between now and when the majority of people who are going to get the vaccine get it, that we still need to be diligent and wear our masks and socially distance. We don't know everybody who's been vaccinated and out in society, to your point. So going to the grocery store and being exposed to the 50 people in the store who haven't yet been vaccinated. So it's critical that we continue to do what we've been promoting since day one, that half the people listen to, of socially distancing and wearing your masks and washing your hands and doing all those things. All of that in conjunction with the vaccine is going to allow us to open our restaurants back up and allow us to open back our society back up. It's what's happening across the country or across the world. When those measures are done in and of themselves, they can be highly effective. But when you add in a vaccine, that really takes you to the next level of protection that we're hoping to achieve.
Right. Okay. Let's talk a little bit about the distribution of the vaccine. It just seems overwhelmingly complicated to me, especially since it's a 2-dose vaccine. And how do you imagine that will be managed within, let's say, our community and throughout the state of Colorado?
Well, Mark, you'll be comforted to know that we've had many, many discussions already about this. And continue to do so on a daily basis. Both myself and my team meet daily to talk about the logistics of it. We also meet once a week with the state to discuss the logistics with them. And they, as you might imagine, are in daily conversations with the federal government and those in charge of the logistics from that end. So some things are changing week to week, and we're sort of flying or adjusting as we go. But the basic logistics are pretty much the same. As I stated before, it's my understanding that the vaccines will be shipped directly from Pfizer in this case because they're the first ones, and probably a week or two later from Moderna, will be shipped directly from the manufacturing to the states. So in this case, Colorado will receive the vaccines in Denver somewhere. I don't know exactly where. And even if I did, I wouldn't tell you. They will be arriving in Denver and kept there. And then they will be subsequently shipped out to the different locations that have already been predetermined, and those people in the know already know where they are. They're going to be shipped out to those locations. And in Clear Creek County, for instance, ours will be kept in Jefferson County because we don't have the negative 80 freezer. And we're working in conjunction with Jefferson County to hold our vaccines until we can distribute them. It's our hope in Clear Creek County that what vaccines we do initially receive, we could literally distribute within a day or two. I don't foresee us getting a lot in the initial batch, primarily because we don't have a hospital, we don't have a lot of healthcare workers in our community, and so we will be receiving far less than, say, any of the front range communities where they actually have hospitals and healthcare workers. Once we get to the B and C aspect of it, which will probably be several weeks after that initial batch, is when we'll be receiving ours. We have 3 nurses in our community in Clear Creek that work for public health that will be administering the vaccines. We also have several backups. The EMS and the paramedics will be helping with that if need be. But like I said, initially we won't be receiving too many vaccines that it will be we will be unable to deliver them in a timely manner. And then moving forward, as we get more and more vaccines, we've done the math in terms of how many vaccines we could literally give out in a single day, and think that we could, once the flow starts, we can keep up with that flow and get as many people in the community vaccinated that want to be vaccinated.
Do you anticipate that vaccination process will include a reservation, such as the reservation process that is included with the COVID testing right now?
Yeah, so initially with the Tier 1, A, B, and C, we're not going to have that. We're in communication right now with, for instance, the EMS and the fire departments and the police departments, sheriff's departments. So they already know what's coming. We already know how many of those individuals are going to be receiving the vaccine and that sort of thing. Once we get past Tier 1 individuals, then we will be likely going into what you are describing as a scheduled. You make an appointment and schedule it. That way, we don't get a rush of 50 people at a time. We can manage it far better logistically, and we can also spread it out over several days, as opposed to everybody showing up on one day. That's what we're planning to do, and are in the process of figuring out logistics of that. But got at least the Tier 1 individuals identified, and are in the process this week of informing them of the rollout.
Now, my understanding is that the CDC guidelines are just that. There are guidelines for the states, and each of the 50 states will decide for themselves the exact folks that will be receiving the vaccination in what order. And maybe Colorado's will vary somewhat from the CDC guidelines. Is that something that we know yet, or is that still in process?
I think you hit the nail right on the head. The CDC guidelines are that. They're guidelines. Every state is not the same. Some states are very small. I'm just thinking of some on the East Coast, for instance. And even though they're small, geographically speaking, they have many major institutions, hospital institutions in them. So the vast majority of their vaccinations would go to Tier 1 as opposed to Tier 2 or 3 and beyond. So it's really, in my opinion, the states will receive the vaccines, the states will receive the guidance from the CDC, but then we're gonna basically vaccinate based on what's on the ground in our state and in our community. If we receive a bunch of vaccines in Tier 1, 1A in Clear Creek, even though we don't have hospital, we would then subsequently go to Tier 1B, EMS, fire, police, etc. So there will be some latitude. The guidelines are that, guidelines, and they're based on best practice and based on what's on the ground in your community.
Yeah, it seems to me that I haven't heard this mentioned, but nursing homes and care facility personnel at jails, universities and colleges, those are places where homeless communities, those are places where the virus has spread so much worse than in the general population. It seems like they would be high on the list, but I'm just a humble reader of articles. What do I know?
Yeah, that's the thing about articles, Mark. You got to sort of read behind the lines or between the lines and understand the general context of something. I think is critical when you're reading something to keep that in mind. You're spot on. The nursing home and nursing care facilities are going to be a higher tier, primarily because they're at the greatest risk of dying and or hospitalization. So if you're trying to minimize hospitalizations and fatalities, that seems like an obvious group to start with. The CDC today is having this very discussion, I think, as we're talking, and all of those things are going to be considered based on data. What does the data tell them should be the priority groups? And then that is also augmented by or thought about in conjunction with how many vaccines are actually going to be available the first round or second round or third round, right? They can make all the recommendations and guidance in the world, but if you only have enough vaccines to cover 10% of that population, that also has to be considered in the conversation of who you're going to actually vaccinate on any given day.
I'm glad we're on that subject of the amount of vaccine available because, if there's one place where the United States has done a great job, it's in preparing for the vaccine, funding the vaccine, and preparing for distribution. I think we've done a pretty good job as a country. That's one voter's opinion. But anyway, this is a big world that we live in, and there are, many billions of people. I mentioned earlier that the U.S. has 4% of the population. It sounds like we're going to be vaccinated in some reasonable time frame, certainly within the next year, we would hope. But that doesn't say much for the rest of the world. I wonder if you have any thoughts on when there might be some worldwide control of the virus.
Yeah, great question. I mean, strangely enough, the rest of the world is doing a great job of containing the virus compared to us, anyway. But the first two vaccines, the Pfizer and the Moderna vaccine, don't really lend themselves well to vaccinating the rest of the world, primarily because of the logistical challenges with it. Having to keep something at negative 80 centigrade is just not going to work for Africa or many parts of South America, or many parts of the world for that matter. So it's going to need to wait until the additional vaccines that are in the queue, the one from Johnson & Johnson and the one from AstraZeneca are the two next furthest along vaccines. Those are far easier vaccines in relation to logistics. One, they're only a single-shot vaccine, and two, they don't need to be kept at negative 80. They only need to be refrigerated. So that is a logistic that most of the world can manage. They're not as effective as the Pfizer and the Moderna vaccine, but the logistics outweigh the efficacy conversation far more. So those are likely to be the ones, and the ones after that, there's probably more than a dozen different vaccines in various states of clinical trials. So those are the ones that are going to address the need across the world. The Moderna and the Pfizer are likely to address, at least initially here in America, but not going to be addressing the rest of the world. So it's just going to be time. Probably spring or summer, all those other clinical trials will be ending, and we'll be looking to mass produce the vaccines and then get those out. And a lot of those other companies, Johnson & Johnson and AstraZeneca, off the top of my head, those two have capabilities of manufacturing that Pfizer right now, Pfizer and Moderna, don't have, primarily because the vaccine and production of the vaccine is a little simpler for Johnson & Johnson and AstraZeneca than the ones for Moderna and Pfizer. So they can produce it a lot faster and create a lot more vaccine than the previous two.
Well, I'm glad you mentioned Africa, because I remember early in the COVID pandemic discussions about once it got a foothold in Africa, how horrendous that was going to be, and as a continent, all the nations of Africa have done such a great job of controlling the virus, and I just I don't know how they did it, but their numbers are low, much lower than they are here in this country, and congratulations and good for them. I had one more question regarding the vaccine.
Mark, if I might say something about, I think the reason Africa is successful is because they have a lot of practice. They're very good at addressing highly deadly viruses like Ebola and SARS and the like. So they've, unfortunately for them, have had many years of practice. So now they understand, and the population understands, most importantly, what needs to be done to address it in a meaningful way. And that's what you're seeing now in practice in Africa.
Well, maybe we'll reach that level of sophistication someday. Anyway, I wanted to ask you a little something about the vaccine going forward. I'm sure that once it's out in the population, has generally been used by most people have been vaccinated. They'll continue to record data regarding the safety and long term of the vaccine, and also they should at some point have reached some sort of a sense of how effective the vaccine remains, and will we need boosters at some point? I don't think there's any information regarding those two issues right now, to my knowledge.
No, and they correct, and they will continue to follow the individuals in the clinical trials. So they're going to continue to follow tens of thousands of individuals, and they will be following both the individuals who receive the vaccine and the individuals who receive the placebo or saline water. And that's where they're going to glean that information that you're alluding to. Is long term, 6 months from now, how much antibody do you have in your system? Is it still protective 6 months out, or 8 months out, or 12 months out? And they will continue to follow those individuals and collect that information, which will then obviously feed our future need to suggest if it lasts 12 months, is it something we only need once a year because it continues to stay around year round? We don't know the answer to those questions yet, but the people who are in charge, the smart people who are in charge of the vaccine development, et cetera, have thought of all those sorts of things and have set up the system so that they're continuing to collect that information over time, because it is significantly relevant in the future moving forward of, do we need another shot 6 months from now, or are we good for a whole year, or does COVID-19 go away completely, which is certainly within the realm of possibilities, but nobody's holding their breath on that one.
Yeah, we'd be out on front of our skis if we made those kinds of assumptions at this point. Dr. Ryan, we have covered a tremendous amount of ground over the last 50 minutes or so. I know that you're a busy man and you've got many things to do today and into the future. Is there anything else that we haven't covered today that you would like to discuss before we leave?
You know, Mark, I would just reiterate the points I've been reiterating since I started in July here. Continue to do what we need to do to stay open and socially distance and stop gathering in your friends' and neighbors' homes. Wear a mask. Those things are the quickest way for us to reopen businesses. I, more than anyone, want to get businesses back open and restaurants back open. The only way to do that is to get our numbers down. And the only way to get our numbers down is to do those things that we've been suggesting and professing for months now, and continuing to double down on those efforts. That is really the only thing in the immediate future, that's going to impact our numbers and bring them down to a level where the state will then allow us to open back up. Vaccine's on the way, but it is not a panacea, and it is going to take time to get that vaccine and to get it to all the individuals to provide us that sort of immunity that everyone needs and wants. But until then, we need to do our part. It isn't about you as an individual, so the sooner you forget that, the better. It's about everyone. And the decisions that you make as an individual, yes, it's your decision to go do something. But it is not and shouldn't be your decision to spread it out to the community and those around you. That's not up to you. You shouldn't be doing that. If you want to make a bad decision and it only impacts you, have at it. But unfortunately, we're a connected society, and the poor decisions that an individual might make could have a significant impact on everybody. We know that now. We've seen it in Clear Creek County and across the state and across the country. You don't live in a bubble. You're not completely isolated from the rest of society, and the decisions you do make do impact others. So we're asking everyone to please make the right decisions. Don't socially gather. Socially distance from other people when you're out. Wear your mask. It's the least you can do. It's not a huge ask. It's a small sacrifice. It's what many other countries already understand and do, and why their numbers are down and they can function more normally as a society than we are. We just need to look in the mirror and realize that. And the sooner we change our behavior as a country, the sooner we'll get back to normal.
All right, Dr. Ryan, thank you so much. And I'm going to continue to wear my mask, and I'm going to continue to socially distance and perform all the behaviors to keep myself and my loved ones and others safe until you and others in the healthcare leadership positions tell me it's safe to stand down. Thank you so much for your time today, and we'll do this again at your convenience.
I appreciate it, Mark. Thank you, and be well.
Goodbye now.